Just ahead on primary care, less than half of the people in this country who have mental illness will ever seek treatment. I sat down with Dr. David Satcher, the 16th Surgeon General of the United States, to find out why. Later, adult and child psychiatrist Dr. Barika Butler joins me to talk about the mental health crisis happening among African Americans. When we talk about mental health in this country, there's no one who understands the subject better than former U.S. Surgeon General Dr. David Satcher. Dr. Satcher is currently the director of the Satcher Leadership Institute at the Morehouse School of Medicine. I caught up with Dr. Satcher at the African American Museum in Detroit. Dr. Satcher, one of the hidden disgraces of this country is the way that we approach and treat patients with mental health disease, in particular in the African American community. How has this country changed recently? How are we approaching this now? Are we moving the needle on this at all?
Well, Dr. Joe, I would like to think so. As you know, as the 16th Surgeon General of the United States, I released the first Surgeon General's report on mental health in 1998. So we've had much more discussion about mental health and mental illness since then. We have passed 2 parity acts, and of course the Affordable Care Act virtually requires all insurance companies to cover mental disorders. It in essence makes mental health an essential health services, requires screening for depression as well as making sure that mental illness is not a justifiable reason for excluding people from coverage. So I think we've made progress. However, I think when it comes to our attitudes, we still have a long ways to go.
Yeah, the stigmata associated with it is very prevalent in all communities, particularly in the African American community. Not to mention the provider component,
Yes.
who also needs a timeout and a check on how we actually feel about treating patients and how we try not to separate the head from the body and make it part of the total package and how we treat patients. There's some lag there also in terms of helping providers understand this issue.
Yeah, we do have a provider problem when it comes to mental health. And as you said, we act as if the brain is not a part of the body. We take mental health for granted. I think some of the recent programs integrating mental health in primary care are really showing progress in that area.
Years ago, there were no records even kept on African Americans who had treatment for mental health disease in this country. So just by virtue of the fact that we've become part of the data means that we are making progress. Do you see us continuing to do that, especially from the standpoint of view of helping educate not just providers but the public also?
I do. I think what's going on now in the country, all the way from the way we deal with mental health emergencies to the treatment of mental disorders in primary care settings, which I think is really critical, to really protecting the brain in a way that we have not before. You know, for a long time, we took the brain for granted, whether it was in football or boxing or what have you. Concussions were ignored. So I think there are a lot of ways in which we are making progress, but I also believe we have a long ways to go.
From an academic standpoint of view, 4 years ago you started a program in Atlanta at the famous Grady Hospital that really linked education on mental health with primary care. Tell us about that.
Well, we actually volunteered 4 years ago to take over mental health emergencies at Grady Hospital. I think there were some people who thought that we needed treatment when we did that. But what we've been able to demonstrate, Dr. Joe, in the last 3 to 4 years is that we could reduce waiting time by 80%, reduce the use of restraints, chemical and mechanical, by over 70%, and actually reduce costs by 40%. And many of the patients that we've seen in the emergency setting, we've been able to connect with primary care providers and community health centers. And what we are able to do is to make sure that they have access to whatever level of care they need. So just as primary care is concerned about cardiovascular disease, diabetes, we're now saying that mental disorders have to be a part of primary care. And we have to make sure that every patient who comes through that door is evaluated for mental disorders, but also has access to whatever level of care they need.
Basically telling the story that mental health disorders are treatable.
Exactly.
Which will possibly, and not so in the near future or distant future, we'll be having a conversation about how this disparity changes, because we know that people, from the numbers, people who have mental health disorders usually die earlier and probably don't enjoy the quality of life. But now that we're talking about how this can be treated, we can not only talk about disparities being lessened and bridging those gaps, but also how we save money. That's not a unique thing to us in this business. Everybody's challenged now with how we save dollars. Yeah,
it's especially amazing when we can improve caring and the quality of care, and at the same time save money. And I think that's basically what we've demonstrated. When patients are ignored, when they sit in the emergency room for 10 to 12 hours waiting for a psychiatrist to come, and then they leave and you don't see them again until our next crisis, that's expensive. That kind of recidivism is very expensive. So I think one reason we've saved money is because we really provided quality care to these patients and sensitive care.
Most of the drugs prescribed by physicians in this country for psychiatric disorders are prescribed by primary care physicians.
Right.
So we're looking at shifting the focus a little bit from standpoint of view and saying, hey, this is where you can begin the treatment and begin to continue the treatment by actually having programs associated with primary care where patients can be seen by psychiatrists and psychologists on an as-needed basis.
And that's a very important point. The point here is that these are primary care centers, community health centers, but they have the team approach to care so that every patient has access to the level of care that he or she needs. But the team also trains, it practices, so that when a patient is identified as needing help, the team functions as a team. And there may be a mental health specialist on the team, but the primary care doctor is a key person here, as he or she should be. Because when it comes to continuity of care, when it comes to the whole patient, that's primary care.
You mentioned the Affordable Care Act earlier. This historic legislation, how do you see it actually aiding this whole treatment of primary care and mental health?
I think the Affordable Care Act has led to a major step forward in terms of the opportunities to really provide quality of care for mental disorders. Patrick Kennedy and I have started a partnership really focusing on how can we make sure that what's in the Affordable Care Act is fully implemented for patients throughout this country. Because the Affordable Care Act says that mental disorders are an essential health service, so they should be covered by everybody. Secondly, it says that we have to screen for mental disorders. Screening for depression very early could save a lot of money, but also a lot of problems in the community. And I won't even get into these high-profile shootings and things like that. But clearly, if we do a better job of screening for mental disorders, it's going to help in a lot of ways.
Absolutely. Let's touch on the hot subject of the day, people actually being victims of violence.
Yes.
Unnecessarily in this country.
Right.
And also how that relates to mental health. We're not too far from a county jail where we sit right now. That jail, the sheriff tells me that 40 to 50% on any given day of the inmates in that jail are psychiatric patients, and they're acting out, so to speak, in the community, and people call and complain and they get arrested, and they have a record after that. And the jail basically does not have the charge of treating them for psychiatric illness. Their job is to keep them off the street and keep the community safe. But after a short period of time, sometime overnight, they're returned to the streets to the same kind of behavior. Whereas if we look at what that recidiveness is, we're talking about missing the boat and not making sure that that population get what they need in terms of mental health care.
I think so. we are dumping our mental health problems in this country on the streets of America in terms of the homeless and into our jails and prison. I remember when I released a report in 1998, it turned out it was estimated that the largest mental health facility in this country, even though it wasn't called that, was the Los Angeles County Jail. Because so many of the prisoners in there at any given time were there because they were mentally ill. And the policemen, of course, have to deal with it. They're not prepared to deal with mental disorders. And yet they have to deal with people who are acting out on the street because of their mental illness. So I think you're right. I think without question, the criminal justice system has ended up inheriting this problem in a big way. There's some good examples, though, beginning to develop throughout the country. There are several judges who have made a commitment to, when people come before them and it's obvious that they need mental care, sentence them to treatment and not to prison. And we're seeing more and more of that occurring.
Interesting. Tell me, what made you, what was the turning point in your career that made you become the forerunner and the champion of mental health conditions in this country?
Well, at heart, I'm a primary care provider. Let me just make that clear first. Because I believe that medicine is about the whole person.
Absolutely.
And so that's where I am. However, when I was a medical student at Case Western, and like on many rotations, I was the only black student on this rotation, and it was in psychiatry. And at Case Western, it was called behavioral science, not psychiatry. There was a young black patient, I think he was 16 years old, who was admitted to the hospital, and he was paranoid schizophrenia. And his paranoia was around race. So nobody white could get close to this patient. And so it turned out they were dependent upon me to be able to get in and talk to this patient. For me, what it meant was I had a great responsibility, but I learned a lot about how to deal with a patient with paranoid schizophrenia. There were some days when I went into his room and I had to defend myself because he attacked me. That was not often, but it happened. But the interest in that case was so great until I was actually asked to do grand rounds on this paranoid schizophrenia. And we treated the patient. He was able to go home stable on medications, and then we did the grand rounds. It's always stayed with me for several reasons. I think about all the people who don't have access to a black physician, who actually need it because of their history and sensitivity. And so that really stuck with me. And I think about people suffering from mental disorders and their families and what they go through. And we're seeing a lot of that today. So I think that case had more impact upon me than anything I experienced in medical school. And it stayed with me since. When I became director of the CDC, one of the first things I noticed was that CDC had all of these centers and institutes, chronic disease, infectious disease, etc., but nothing on mental health. So I appointed the first associate director for behavioral health at the CDC. And now we're really trying to get a center on mental health at the CDC.
Raise the level at least.
Yes.
For that approach.
That's
excellent.
Exactly right.
Well, the passion certainly comes through for this portion of healthcare. Mm-hmm. Good. We've been talking with the Honorable Dr. David Satcher, who will always be the 16th United States Surgeon General. Thank you for joining us on Primary Care. Thank you. Great. Thank you for having me.
Once there was a boy who did the same thing again and again. One day, he was told he had autism. He got help and slowly learned how to live with it better.
Early intervention can make a lifetime of difference. Learn the signs at autismspeaks.org.
Mental illness is often stigmatized or even ignored in the black community, leaving many people untreated and undiagnosed, even though there's help available. My next guest, Dr. Barika Butler, is a child and adolescent and adult psychiatrist. She is also the medical director at the Samaritan Behavioral Health Center and CEO and medical director of the Wellness and Achievement Center of Michigan. She joins us today to talk about the mental health crisis in the black community. Dr. Butler, welcome to the show.
Thank you.
This stigma that continues to plague not just our community, but the community at large in terms of having a mental illness is around and alive and well. Will you comment on how we can begin to combat that?
So stigma is a huge problem in our community, particularly, and throughout the United States, really. One of my issues is the term mental illness. This is an illness of the body, just as any other illness, like cancer, hypertension, diabetes. We don't stigmatize people for having cancer. We don't stigmatize people for having diabetes, but we do stigmatize people for having depression or schizophrenia. I think one of the biggest things that we can do is educate our community. It has to start with education.
What are some of the other barriers you see as a practicing psychiatrist that face your patients in getting good mental health treatment?
Well, one of the biggest barriers is and continues to be access to treatment. And access to treatment goes back to the insurance companies and them providing enough care and enough visits. Oftentimes, insurance companies would say things like, you have 10 sessions of mental health available for you this year, and you can't treat depression in 10 sessions. You can't treat schizophrenia in 10 sessions. You would never expect a cardiologist to say, you have 10 sessions for us to get your heart fixed. And
stop your medication
exactly,
in the process. Yes.
Exactly. So we have to do better with providing care. The Mental Health Act, Parity Act has done a good job at that. Obamacare, the Affordable Care Act, is helping with that. So we are improving access to care. I've seen those changes on an individual basis, but we've got to do better. The other things that we have to remember is that often people who have mental illness are suffering from homelessness, they're suffering from difficulty getting around, transportation needs, financial needs, and all of those things impair somebody's ability to take advantage of what's available for them.
So just like all the other diseases that you pointed out, we have some of the same social related problems with mental illness, just like everything else that we
Absolutely.
treat, including the stigmata. What are your patients doing now? How are they faring in terms of what the landscape has to offer them in terms of how they get care, where they get care? Are we meeting their needs, or are we still struggling and behind the 8 ball to do that?
I do think that we're doing a better job, because now with the Affordable Care Act and mental health parity, we're at least able to offer them more services. So we can engage social workers and therapists that can come in and do case management type of interventions and help people get to their appointments. It has been helpful because we've been better able, with the changes that have been made with insurance, to connect people to primary care physicians. As a psychiatrist, I've often found myself being the primary care physician for people who suffer from mental illness because they don't care for their other needs. So I'm looking at their diabetes and hypertension as well, but wanting them to get that regular care from a primary care doctor. So I think we've been doing a little bit better with that, just because we do have access to send them to their primary care physicians now. And when we can get their other medical issues under control, it makes it that much easier to treat their mental illness.
We have to put this head back on the body and treat the entire
Correct.
body.
It's not separate.
You know, in other industrialized countries, a good percentage of the psychiatric services, support services, and treatment is done in the home. Is that a possibility in this country? Do you see that we could move to that arena?
I think that there are pockets where we do that now, just with home health care aides and things like that, home psychiatric nurses, and we try to do that. I can't see our insurance companies paying for that. It's expensive, and it would be nice to be able to do that and provide those care for our patients, but I think that the access and who's going to pay for it is going to be the biggest question.
Again, the same problems we have across the spectrum of healthcare.
Yes.
We're going to take a break. We'll be right back.
There are over 34,000 Daves in Southeast Michigan. Big Daves, medium Daves, baby Daves. At Henry Ford Health System, we're inspired by every Dave out there, and every Shannon, Charisse, Miguel, and Ahmed. Because no matter your name, we believe care should be built around you, not someone like you or near you, but care designed for just one person, you. Henry Ford Health System, all for you.
We're here with adult and child psychiatrist Dr. Barika Butler, continuing this discussion on the mental health care in our community. Dr. Butler, what role does the family play with these patients, assuming there is family support?
And that's an important piece, assuming that there is family support, because often there is not. Mental illness has a way of breaking families apart. Many of us have that aunt or that cousin that doesn't go out of their room and stays quiet and sits in the dark, or that we say is a little bit crazy or has been, as the old folks would say, touched. But using those terms doesn't get us very far in getting them treatment. We have to understand that this person is not crazy, and I don't like that word. This person is suffering from an illness that is affecting their ability to think, function, talk, eat, just like any other illness would, and it affects families greatly. What we have to do, again, education is huge. Taking that stigma away and saying, this is not a bad thing. If your mother was suffering from cancer, you would help her. You would want to help her with that. You would get her to the doctor. Same thing. This is not an embarrassment. It is something that can be treated. And if you get someone into the right therapist, the right psychiatrist, get them started on medications, you can do that. And often the first step is that family doctor. If you trust your family doctor enough, get them in there, and then that family doctor can decide if it's something that that family doctor can address or if they need a referral to a mental health specialist.
It's a very interesting subject in that we still have these cross the line issues here from other disease states. I like the phrase, if mom had cancer, would you just sit on it and say, you know, there's nothing we can do about it? Most recently, we're going through the choices that patients make in terms of treatment of all kinds of diseases, especially in diseases that supposedly are end-of-life diseases. I'd like to try that experimental drug anyway. But a mental health patient would not be one that would step forward and necessarily say, I want to take that medication, or even to the degree to say that I need some help. There has to be a support mechanism around them to bring out the fact that, yes, you do need some help sometimes.
Absolutely.
And unless we can address that, we're probably going to miss a good percentage of these patients. Tell us something about the medications that we're using now. What does the future hold, and where are we going? Do we have any exciting blockbuster things that are going to make a big difference in this arena?
Well, you may or may not find this interesting, but psychiatric medications gross some of the highest numbers in pharmaceutical. Number one,
yes,
okay? Yes. And it's big business. It's very big business. That's good in a way because it does allow for new research, new things coming out. There have been a number of new antidepressants and antipsychotic medications that have come out, which has been very good for our patients in that many of them have fewer side effects, which is something that people have often been worried about with psychiatric medications. No, I'm not going to take that. It's going to, make me suicidal, or it's going to make me gain weight, or it's going to make me have tics or some kind of other thing that's going to make me not look good. And that has been an issue for patients in the past. The new medications are better with that. The downside being access. As you know, the newer the medication, the more expensive it is.
It has been said in this community, at least, that the jail cell bed has replaced the hospital bed. Or the coffin has replaced the hospital bed because so many of these disease states lead to the demise of the patient. From a political and a social standpoint of view, we were touching earlier on how so many patients who are rounded up in this community and wind up in jail overnight simply because they have a mental condition, and in the morning they're turned out with basically nowhere to go. What can we do as a health community and to address some of those issues? What can we do to actually improve that kind of care that popular patients, which a lot of them are homeless, that population of patients needs?
I think fundamentally it's what we do for all medical care, which is primary prevention. So if there are things that we can do to step in and make sure that our children are exposed to the proper interventions early, to help them navigate what may turn into mental illness, we're going to do better. If we reach these people early, we're going to do better. Now, it's difficult in that oftentimes, like you said, the support system isn't there. And because it's a cognitive disease, people aren't thinking necessarily correctly to know that they need help. Then they end up homeless and they end up losing their jobs and all these things that could have been prevented had they seen a mental health worker soon enough to get on medication and help them recover. Now, when they end up in the jail cell, oftentimes we would think of it as being too late, but it's not. If we can help to create a pipeline where, okay, if we're going to pick these people up, we bring them in because their mental illness is manifesting in an aggressive way that lands them into a jail cell. Let's have a place for them to go. Our shelters, if that's where we're going to send them, why can't we have mental health workers that visit those shelters and provide care to those people? That is something that I think we could do. Why can't we have someone who can call the families and arrange for case management type services. If someone ends up in your jail cell, pick up the phone, try to, put together some services for that person and not just send them out. I know that the way things are set up now, the resources are scarce, but we gotta start with some primary prevention, and then when they end up there, we gotta figure out what the other alternatives are.
Black folks, spiritually based, this community, lots of people will identify with a church or a congregation, but they may not necessarily participate and attend like they should. But my question is, what can our religious community do to assist in this effort?
For me, the religious community is huge. It's a big factor. It is what many of African Americans and other people who are not necessarily native to this country count on for their strength. It's what our grandmothers taught us to believe in.
That's right.
And when we walk into church on Sunday, we have to have someone who's standing there and saying, depression is not the devil. Depression is a medical illness. And having the Black church stepping up and providing services. I know that many churches will have times where they'll check your blood sugar or check your blood pressure at the health fairs.
Right.
I want to see someone sitting there with a depression screen. I want someone sitting there asking those questions and saying, it's okay. That reassurance that this is okay. And until people recognize that it's okay, they're not going to seek help.
Amen. We've been talking with Dr. Barika Butler, adult and child psychiatrist. Thank you for such an interesting interview. We hope to have you back in the future.
Thank you. Hope to be asked back.
For Primary Care, I'm Dr. Lonnie Joe.